Piedmont Behavioral Health Care is the agency that I work for, and we are responsible for all of the mental health, substance abuse, and developmental disability services for our 5-county catchment area, actually 7-county catchment area. And Davidson County is one of the 7 counties that we're responsible for. We typically serve individuals that either don't have insurance or have Medicaid as their insurance, because those are going to be the folks that run into the most barriers in terms of accessing services. I have been with PBH for about 7 years and worked in various departments, but I did spend some time working specifically as a case manager with children and youth, and my caseload was about 20, it varied between 17 and 20 children, and they range from ages 5 to about 17. What I would like to do is just have more of a informal discussion, and then whatever is not covered through this discussion, we can go through some bullet points through the PowerPoint, but if you go through the PowerPoint after today, and if there are specific questions that you come up with, I'll leave you all, and it may already be on there, my email address. And if there are things that we don't have time to cover, because how much time do we have?
An hour.
An hour. Mm-hmm. So if there are things that come up, definitely feel free to send me an email. Yeah, it's very small, so let me give that to you. I didn't realize that came out that way in printing, but my email address is LaShay.Avery@PBH, P as in Paul, B as in boy, H as in Harry, PBH Solutions with an S on the end, .org. So that's LaShay.Avery@PBHSolutions.org. And my direct line is 704-721-2713. But if you don't want to make a long distance call, you can also reach me at a 1-800 number, which is 1-800-939-5911. And that's the PBH 1-800 call center number that's manned 24/7, 365 days a year. Obviously, I'm not there 24/7, 365 days a year, but a message can definitely be taken, and it's always a live person that answers that 1-800 number. But I think in having this, the group discussion will help us to talk about mental health and substance abuse as it relates to children, and specifically from a developmental context. Because how many of you are aware that the teen brain is still developing throughout the adolescent years? That research hasn't been out very long, but it's really it can be up through the mid-20s before a brain is fully developed, which definitely explains why teens and adolescents make some of the choices and the decisions that they make, because they're especially that executive functioning of the brain takes the longest to actually be fully developed. And so a lot of times, when you ask them why have they done something and they say, I don't know, they really don't know, believe it or not, because that part of the brain is still developing. So I think with this discussion, we'll be able to understand that a little bit better, and it'll give you ideas. Sometimes we often know more than we think we know, so I think this discussion will help us to see what we don't know, and then at the end we can have some time for Q&A and possibly address some of the things that you really didn't know. Yes, ma'am. But with mental illness, it can be biological, and that it's what you're born with, and that can still be addressed, and people can still recover from that. But it can also be environmental, which is partly what you described in terms of, and I think even what you described.
She has an anchor issue.
And that's going to be biological from the parents, in terms of, because of the substances that they use during conception, then there can be deficiencies in their neurological disposition that negatively impacts the child. But not even just someone taking drugs or a parent taking drugs, but if you're in an environment that is dysfunctional, that can have negative impacts as well. That can lead to depression, bipolar disorder, things along those lines. It can be environmentally induced. And then a third component, which would be trauma, someone experiencing trauma, and that can be trauma from physical contact, as well as just having gone through a traumatic experience, having lost a loved one, or having witnessed, very violent situations can also induce depression and other mental health disorders. And sometimes that just show themselves through behavioral actions. And hopefully this discussion will help us to understand that as well. So just from the things that you've seen and dealt with, what would you consider normal behavior? Would it be experimenting with drugs, having friends, having sex, or being alone? What would you consider normal behavior for teens out of those four options?
One more time.
Experimenting with drugs, having friends, having sex, being alone. Yeah, the answer is having friends. All of those, the other choices, experimenting with drugs, having sex, being alone, they can be typical of a teenager, but they're not what's considered normal behavior. Normal behavior would be the second choice that I gave you, which would be having friends, because they're definitely into, having friends and what their friends think, and the whole thing that goes along with peer pressure and everything that comes along with that. But having friends would be what would be considered normal behavior.
Wouldn't some teenagers, wouldn't they consider some of those other options as being normal, because it's just part of being a teenager?
Being promiscuous may not be normal, but being active, sexually active as a teenager, I don't think that's very abnormal.
These days, no.
Yeah, exactly. Unfortunately, I don't think it is. Like I said, if you're promiscuous, then yeah, maybe that's crying out for something.
Yeah, and there's no all or none. It's definitely going to vary from individual to
As far as
individual.
normal, we're thinking in terms of what we think is normal. But as a teenager, those other things could be a normal part of life.
Could be normal for them, correct. That is correct. What are some objectives that don't describe adolescence? Family-oriented, self-assured, and logical thinkers. Experimentation, conflict, conceptualization, and narcissism. Ambivalence, distance from parents, occupied, and loneliness. And ego, identity, sexual exploration, and conceptualization. What are some objectives that don't describe teens? That would definitely be the first option that I gave you. Family-oriented, self-assured, and logical thinkers. That does not describe most teens, but everything else certainly does. How many American children have difficulties that are diagnosed as serious mental disorders?
So 6 million?
It is 6 million. At least 6 million, which is a lot. And that's definitely the population of folks that we're coming in contact with. What are not main features of ADHD, which stands for Attention Deficit Hyperactivity Disorder? What are not main features? And the options that you have, they don't seem to listen, easily distracted, and excessively active. The children finish work that requires concentration, and they don't often have friends. The children are talkative and have serious difficulty waiting their turn in games. The children may have learning disabilities and emotional problems. So which is not a main feature of ADHD? It's C, the children don't finish work that requires concentration, and they often don't have friends. And why would you think ADHD would impair their ability to have or not have friends?
Their lack of focus, their lack of being able to build a relationship, lack of being able to cope.
Right, exactly. Because sometimes those deficiencies that they have, the inability to concentrate, the inability to socialize, that's going to impact whether or not you're able to make friends with someone or not. So in turn, that's going to have a negative impact on your ability to have and keep those friends, because you might be looked at as annoying or irritating, or things that often keep people at a distance from you.
My son said he felt like he was different and out of place, so he tended to not be
Exactly.
a child like this. And he said he felt like he was, like in our society we call it the minority, he said he felt like he was the outcast. He felt like
Exactly, because sometimes those deficiencies that they have, the inability to concentrate, the inability to socialize, that's going to impact whether or not you're able to make friends with someone or not. So in turn, that's going to have a negative impact on your ability to have and keep those friends, because you might be looked at as annoying or irritating, or things that often keep people at a distance from you.
my son said he felt like he was different and out of place, so he tended to not be a child like this. And he said he felt like he was, like in our society we call it the minority, he said he felt like he was the outcast. He felt like he didn't fit in with that group of people because he wasn't like them.
And that's very characteristic of ADHD, or someone with ADHD. As many as 1 in 10 children between between what ages experience persistent feelings of sadness which is the hallmark of depression? Would you all say 3 to 5 years, 6 to 12, 13 to 15, or 16 to 18?
6 to 12.
Yep, and that is correct. And why would you say 6 to 12?
Well, this paper says.
The answer there.
But I would have thought 13, I would have thought teenagers, not so much, 6-year-old, and being diagnosed with depression is a little shocking. I would have thought teenagers more so fitting in and.
Yeah. But when you look at it from a research and statistical standpoint, it is ages 6 to 12.
I see it down there in the elementary and the middle school.
And you do see it.
Yes, big time. With the girl I had in middle school, she is so depressed right now. And she's only 12 years old.
And unfortunately, it seems to be
knew what depression was.
the child, or not knowing.
Yeah, she's really depressed right now.
And she's in 6th grade.
She's in 5th grade.
Fifth
She was
grade.
held back. But that's how she's a normal student in the 5th grade.
And it seems to be impacting children at more and more younger ages at a faster rate. And tons of research is being done to look into why that's happening and occurring. And hopefully, as those findings, come out, we'll be able to make them aware to the community. Which of the answers is a symptom of depression? Stereotype movements and mannerisms, no desire to use drugs or alcohol, constant complaints of aching arms, legs, or stomach, and with no apparent cause. And finally, alternation over days between elevated high and low emotions. The answer would be constant complaints of aching arms, legs, and stomach with no apparent cause. And that's partly because as an adult, you have more of an ability to express why you're feeling sad if you're asked that direct question. Whereas a child, they might not be able to conceptualize what they're feeling, but all they know is they hurt, And so it may come out in them verbalizing their sadness in that way. My legs hurt. I don't feel well. I don't want to go to school. I just don't feel good, because they haven't they're not able to actually verbalize what's really going on and why they feel sad or bad. But oftentimes you will hear that with kids with depression, them describing themselves as, just aching and really without any reason. There's no fever, there's no sickness, but they don't feel good.
So are you going to tell us what to do when they do that? Because you might have heard that before.
What you can do is take it further, give them very concrete options of asking questions, because they're not going to be able to necessarily, again, verbalize what it is that they're feeling, but you want to give them very black and white, concrete options, of what, based on your relationship with them, what could be going on, that they can then give you a response that then you're able to help them access what the resources that we'll talk about that might be able to help them address whatever is going on, whether it's family, what's going on at school, home.
Does talking about it for a child, does that help get it out enough that you're on the road up instead of continuously?
It really depends on the child. For some people, for some children, just talking about it with that adult would be enough. But for other children, they might need ongoing therapy to really talk about it and get to the root, because it may take more than one conversation to figure out how to best help them to get past whatever it is that's causing the depression. But outpatient therapy is definitely an option of ongoing treatment and being able to talk about that with the professional.
And these kids don't have the resources that some kids do. They can get outpatient therapy in what way?
They can get outpatient therapy through PBH, through Piedmont Behavioral Health Care. We don't actually provide the services, but we're like a Blue Cross, a Blue Shield, in that we have a network of providers that are contracted with us to be able to provide those services, whether it be outpatient therapy where they're being seen once a month, or whether it's something that needs to be a little bit more intensive where they are seen more regularly. And it might be that they need medication, and that can be accessed through those same providers. And I'll pass this around for you all to be able to take one, but there's a 1-800 number that's on the back of this brochure, and mental health and substance abuse treatment options can be accessed through that 1-800 number. When you all can make a referral, but because you're not the parent, it would have to be the parent or the legal guardian that actually approves and requests those services for that individual child.
So do y'all work with Daymark next door?
Daymark is one of our contracted providers.
Provide all our kids to go there.
Mhm.
Yeah, they can walk in and get
And
service.
some people, it's important to know that because everyone is very familiar with Daymark, the community can tend to think that Daymark is the only option, but some people don't receive, some people don't like Daymark, just like as we go to the doctor, we may have a better experience with one doctor than we do with another. So we have a list of providers that are contracted with PBA, so Daymark is not the only option. Monarch is another option, RHA is another option, and they all have what's considered a comprehensive service array. So they can provide medication management, they can provide outpatient therapy, they can provide intensive in-home services where a team of people will come into the home and work with that individual, well, not the individual, but work with that entire family component. Because as you all know, as mentors, it's often you have to deal with the whole family in order to really get anywhere and to really move forward in a mental health or substance abuse situation. So there's a service that's called Intensive In-Home, where a team of people that consist of a clinician, a case manager, to really come in and help the entire family. So those services can all be accessed through the PBH 1-800 number. Do you have a question? Oh,
I wanted to add, if you have this issue, if you see something like this, that's when you'll go to your site coordinator to talk to them about it, and they can sort of run the wheels. You don't need to contact the family personally.
no, that's okay. No, I'm sorry. I understand. Which is not a symptom that's associated with conduct disorder: physical cruelty to animals, forcing others into sexual activity, breaking into homes and destruction of property, lack of remorse for hurting others. So which symptom, this is a kind of tricky question, which symptom is not associated with conduct disorder, which is a mental illness specifically attributed to children. So as an adult, you would not be diagnosed as having conduct disorder. It's a specific diagnosis for children and adolescents. And which of those characteristics that I described do not describe a symptom you would think associated with conduct disorder?
I would say the same.
Physical cruelty to animals, forcing others into sexual activity, breaking into homes and destruction of property, lack of remorse for hurting others.
I don't lack of remorse.
That is correct. And because everything else that was described actually is associated with conduct disorder. And I'll leave enough time at the end for you all to take any of the brochures up here. But what I also have on this table is what's considered the DSM-4, is the Diagnostic Assessment Manual. And it lists all of the mental disorders and their definition in this book, and conduct disorder is one. And again, that's specifically for children and adolescents. Most of the time, children that have a diagnosis of conduct disorder can go on to become your sociopaths. So that's what that can lead to if not addressed. Which of the following is one of the stages of a crisis? The person has an identity disturbance and an unstable self-image. The person experiences an increase in emotional response. They respond with hostility, tension, and guilt. The person becomes extremely forgetful. The person has recurrent suicidal behaviors and gestures and threats. The answer is the person who experiences an increase in emotional responses, and they respond with hostility, tension, and guilt. That would be what's considered a crisis. The stages of a crisis. Which of the following is not a reason adolescents typically receive mental health services? Recurrent thoughts of death, violent aggression behaviors, running away, life-threatening drug and alcohol use. And that's, again, a tricky one because it says which of the following is not a reason adolescents typically receive mental health services. The answer is recurrent thoughts of death.
Oh, yeah, not suicide.
Yeah, okay.
Because that can actually be, believe it or not, that can be pretty common among teens for them to think about death and or suicide. So
Their death or somebody else? Not
death,
suicide, but
death in general,
death in general.
can actually be pretty normal for teens. Which of the following is not a barrier to care for adolescents needing mental health services? Parents showing up to an adolescent counseling appointment. Adolescents fear that certain issues may be revealed. Parents don't follow up with recommendations. The parent and adolescent have a lack of understanding about the diagnosis. So which of the following is not a barrier? Which of those that would not be a barrier would be parents showing up to the adolescent's appointment? That's definitely not a barrier, because that's what you want to happen. You want parent involvement, because the more the parents involved, the more likelihood there is of that family and that child being successful. Which of the following, and this has, which of the following would a mentor approaching an adolescent, which of the following would a mentor approaching an adolescent with mental health concerns not do? So which of these options would it not be good for you to do? Provide a calm and relaxing atmosphere, provide the adolescent with numerous choices, repeat yourself numerous times, if possible, take time to let the story unfold without prejudging the situation. So which of those options would you not do, or would be a good idea for you to do? The numerous choices. And why is that?
Oh, it confuses them.
Yeah.
Probably really good at the
Yeah.
process of it.
Yeah, the least amount of choices for teens, the better, because they can't really process several things. It's going to be more difficult for them to process several things and several choices at one time. So the least amount of choices, the more concrete, the better. Only a couple more here. True or false? Which of the following is false for a mentor when approaching an adolescent with mental health concerns? There is a possibility of violence. Don't understand the information given by others regarding behavioral health clues. Make promises that you can't keep in order to keep them safe. Don't allow others to interact simultaneously while you are attempting to talk to them.
I can't remember the words. Lying to them, basically.
Yeah, yeah. It says make promises that you can't
Right.
keep in order to keep them safe. That's the last thing that you want to do in interacting with an adolescent. And then finally, which of the following is not something to remember when communicating with adolescents? Get the person's attention first. Make your statement one time and one time only. Limit input and don't force a discussion. Be simple and truthful. And these are tricky because it keeps throwing in the word not. So all the other things, there's out of the 4 choices that you have, there's only one that you don't want to do, and the one that you don't want to do is make your statement one time and one time only. You need to be able to be willing to repeat things as many times as possible. You definitely want to get a child and a teen's attention first before you proceed with a lot of instructions and solutions. And then you definitely want to be simple and truthful and allow them to have a discussion about whatever it is that's going on, if they're willing and open to wanting to have a discussion. The thing that I want to go over from here on page 2 where it says A is for adolescents. I think that really that's an acronym. Adolescence is the acronym, but I think it gives a very good description of what teens are going through, and gives you a really good idea of just their state of mind, and in terms of the ambivalence, not really knowing who they are, what to do, where to go. But with having you all there and being a part of their lives, hopefully to give them and provide them with some direction, I definitely think helps. But teens in general just are very ambivalent. It is a part of the natural developmental process to be different from their parent, distant from their parents, because they're trying to figure out who they are, usually within the context of their friends, just trying to figure out who they are as individuals. They can definitely seem very preoccupied and very narcissistic in that everything revolves around them. Things that seem small to us are, can be huge to them, and they can tend to be dramatic at times. But again, that's all a part of the developmental process. It's very common for them to be sexually explorative and just trying to figure that out. Can often have difficulty with conceptualizing things. Again, just that ability to really process and put things in the proper context, and just have a difficult time communicating because they're not really sure what they're thinking and feeling, and so they can have difficulty with verbalizing. To us as adults, that can be very frustrating because you feel like you can't really help someone unless they tell you what's going on, but they have a hard time really knowing and figuring out what's going on. So oftentimes it can be like trying to put a puzzle together based on the bits and pieces that they give you. So just keep that in mind and figure out a gazillion ways to ask the same question. Specific diagnoses that pertain specifically to teens and adolescents are depression, anxiety disorder, again, conduct disorder, and then each of those diagnoses, you can see the descriptions that are listed there. So whenever you see those symptoms displaying themselves, definitely utilize your coordinator to be able to access services and treatment for that individual.
And how young do you have to be to have this conduct disorder? Because some of these folks that have elementary age, could they have the conduct disorder?
They could. It can go as young as 3.
Whoa.
And a lot of times, because people don't necessarily have the right terms to describe conduct disorder in, they might just say, this is just a bad kid. You might hear that a lot. They're just bad and they're doing this or that. But really, if you look at the environment and if you look at the other things that are going on, that individual could be assessed for having conduct disorder. If there's really no rhyme or reason to why they're acting out and behaving a certain way, that would be someone that's a candidate for being assessed.
Here's a question. I have a friend he's been telling me about his lunch buddy who lost his father in the last year. And this young man has been, he's never really had any issues, but now he's starting to act out and trouble at school.
Mm-hmm.
Talked about guns all the time. Should this friend of mine be talking to the psych coordinator about that?
Yes.
Think so?
Would that be a trauma-related thing, maybe like response from that? Or?
It could be, and it could be a number of things, but it's definitely not normal to just have that kind of change. And so you would want to figure out the reasons behind it. And because kids are some of the things that are going on now with the school shootings and things like that, you never want to take anything like that lightly.
I've got a question about ADHD.
Mm-hmm.
What is the typical diagnosis for that? The process to diagnose a kid as just being active, energetic versus ADHD, medicine, and kind of, I guess, and then what is the treatment response? Is it automatically a medicine prescription type response for that, or kind of how's the process of saying, I think this kid has got this, what do you?
Yeah, because in doing a clinical assessment, there's a series of criteria that would have to be met in order for that child to be diagnosed as having ADHD. And then in terms of treatment, that can vary from child to child. Some people just change their diet and they can see a change. Some people change their environment and provide a lot more structure for that child, and the behavior can change or be controlled. Some people do require medication, and then the behavior can change as a result of the medication. So it really does vary from individual to individual. But in order to be diagnosed, a criteria based on the DSM-4 would have to be met in order to actually receive that diagnosis. And that's going to be something outside of just the normal hyperactive child, because some kids do just have a lot of energy, but they're not ADHD.
When I know my buddies in the county schools, and so I'll probably get like 4 additional buddies because we sit here in the lunchroom and eat. And I know I thought I heard a couple of them say something about, their medicine. And I'm like, what medicine are you taking? And I haven't known them a long time because this is the first year they've been in this class. But I thought, medicine for what? I didn't wonder if all of them was that active, and girls and boys, but it seemed like it was 2 or 3 of them that made reference to being on some kind of medicine and ADHD. And I'm thinking, is it really that many kids that's ADHD or?
And a lot of people do feel like it's overly diagnosed. So it just depends on, your personal opinions about that. But a lot of people feel like it's overly diagnosed, and kids are being overly medicated. And one thing is definitely true. There's really not a lot or enough research out there to really show the long-term effects of children taking the psychotropic meds and what kind of long-term effect that will have.
Mine was ready in 3rd grade, got in trouble one time at school. I went there, and the principal came to me and says, he just needs a pill. That's the diagnosis. He needs a pill. And that's please don't.
Unfortunately, it can be used like a quick fix.
Yeah.
And that's unfortunate for the children.
In my child's case, it wasn't something that started before he went to school. It was something I had already noticed at home long before he even got to school. I noticed his inability to even sit at the table and have a conversation. We used the dining room table as a means of time that we were eating to talk about things we want to talk about. He would even be in the conversation. He would be busy juggling something else or tapping with his fork, and we would constantly have to take things away. Now, we thought by taking it away, this would make it clear up, but it did not. So by the time he started kindergarten, we noticed he didn't make choices. He didn't get his book bag. He didn't do. So his started long before he got to school. And so we took him to the doctor and had him diagnosed, and they said they thought that's what he had, but they wanted to do. So Dr. Timberlake's the one that did him, and we went through a bunch of tests where we decided as parents not to do medication. We changed and had more structure by taking things out of his room when he misbehaved, and then we modified his diet and took a lot of sugar content out. And my child went all through school with no medication and never had to do that. And he's now 23, and he's learned on his own. When he starts having days that I call it going backwards, but for him, he says it's most of the time it's an anger, or he's getting frustrated with something, or something's not fitting in. He'll take a walk or move himself from that situation and move him into something else. Because I don't believe in medication if you can get around it. But there is a child that's involved in the lunch buddy program at Piedmont Elementary. I wouldn't want to be the teacher without that child having medication. Because I've seen this child without it when its mom forgot to send it. And I've seen it when it's had it, and it's able to focus. She can sit down and eat, and she feels like she fits in. So she needs it.
And that's true for everyone. It just depends on the
I don't
individual.
think she can make it without.
My little girl is on medication, but I worry about who's monitoring this, because there are a lot of days where, I need her for lunch, she won't touch her food and has absolutely no energy.
Then her medicine probably needs to be tweaked. It's probably too strong.
Well, and also she suffers from allergies, so I'm worried that
That's
they
something I
might be
talked to the doctor.
given.
That's what-
But I'm not sure who is following that. I mean,
Bring it up to your coordinator and let them talk to the doctor.
Yeah.
Especially they're not eating, that
Well,
always gets me there. If you think it's because of medicine or something.
But it
Yeah.
will have an effect on the medicine, that will have an effect on the appetite. They told us that.
yeah.
Said if
Yeah,
you
but
eat
really,
more,
literally,
you
she does not touch anything on the
I
little
bet
tray.
hers is too strong.
A lot of them are appetite suppressants.
Yeah.
But talk to your site coordinator and
Mhm.
see if she can contact the parent
Yeah.
and see if the parent has had a thought to,
Yeah.
that y'all noticed that she's not eating. They can see if there's any follow-up.
And oftentimes, as long as if it's presented in a way that you're not accusing the parent,
Yeah.
so that they don't get defensive, but if it's presented in a way that
Yeah.
just an observation that you made, and then they can really follow through and find out what's going on. Recovery is possible, and the work that you all are doing does matter and does make a difference. And I would definitely encourage you all to continue in doing the work that you're doing. Thank you for serving as mentors, because it's definitely needed and important. And the PBH 1-800 number that's listed on the back of the brochures, again, you can give that information to, I forgot what was the title of the person you said,
Your
to
site
their,
coordinator.
to
Or
their-
you can call us and we'll talk to the site coordinator.
to try and get services for the individuals that you're working with, if you see that there is a need for that.